you, everybody, and thank you, Sharon, in particular, for asking me to talk about one of my pet topics, that is anatomy. I've been asked to talk about the anatomy of aortic stenosis. I could talk about morphology of aortic stenosis. I could talk about the anatomy of the effect of aortic stenosis on the heart, which I will briefly do. But I think because severe aortic stenosis usually involves intervention of some sort, either a surgical aortic valve replacement or an interventional percutaneous intervention, I think I should spend most of my time talking about the anatomy of the aortic valve and its adjacent structures. Now, how do I get this? Is there a button to push here?
The thing to do that is go on the keyboard. Just go down.
Thank you. Yeah, thank you. So now this is as you can see, an aortic valve viewed from the aorta. This was a section that I did with Professor Fiona Stewart many years ago for teaching purposes at the University of New England. And it's to show you a normal aortic valve. It contains 3 cusps. Each cusp has a name. The shape of the cusps are said to be semilunar, which means half moon-shaped. And you can see the free margins of these cusps are slightly thickened, and the central port here, the central point of each semilunar free margin is a little bit more thickened than the rest of it. And this is known as the nodulus aurantius, which surgeons take advantage of. It's thick enough to hold a suture. And if you have a prolapsing cusp, you can actually plicate the leaflet in this point here and prevent the prolapse and therefore create competence. Now you can see here in the aorta, just above the aortic valve, these are the sinuses of Valsalva. And the sinuses of Valsalva are important because they are integrally associated with the annulus of the aortic valve. They basically are anatomically a unit, and they are named according to the coronary arteries that arise from them. So this one over here gives origin to the left main coronary artery. This one gives rise to the right coronary artery, and this one is the non-coronary sinus of Valsalva. And similarly, the leaflets of the aortic valve are named as left coronary leaflet, right coronary leaflet, non-coronary leaflet. Now, we can't really talk about the anatomy of the aortic valve unless we mention the ascending aorta, because as I've already mentioned to you, the annulus of the aortic valve, which you can see drawn here, is basically integrally associated with the aortic sinuses. So the ascending aorta starts at the aortic annulus, and it basically ends at the innominate artery, where the aorta becomes the aortic arch. The ascending aorta has 2 parts. There's the sinus of Valsalva, which I've mentioned, and the tubular aorta, which has no branches and extends from the sinotubular junction to the innominate artery. Now, the sinotubular junction is the point where the top of the commissures of the aortic valve extend to. And so the aortic annulus extends all the way up to the sinotubular junction and dips down to the left ventricular outflow tract down here. Embryologically, the aorta is, or the pulmonary artery in the ascending aorta, are known as the primitive aorta, and the developing heart is known as the cardiac tube, and the two basically fuse at this point here. You can see this area here where the primitive aorta and the cardiac tube embryologically will fuse, and this is known as the ventricular arterial ring. You can see that the basal ring, which is a horizontal line around the left ventricular outflow tract at the nadir or lowest point of the aortic annulus, is a little bit below that. Echocardiographically and on CT scan, this is the diameter here is what we would call the diameter of the aortic annulus, but anatomically, the annulus is very different to that, which I've discussed. Now, the other thing to note about this is that the subcommissural triangles here are part of the left ventricular outflow tract. And above the annulus is the aorta. But you can see here that the subcommissural triangles are partially formed by primitive aorta, partially formed by cardiac tube. So it's a composite structure. And so also is the sinus partially caused here by cardiac tube until you get to the ventricular arterial ring. So it's a fairly complicated structure. It's not anywhere near as simple as you might imagine if you're looking at the aortic annulus in an echocardiogram or on a CT scan. Now, just a few other things about the aorta. This red line here represents leaflets of the aortic valve, and I put that here to show you that the leaflets, when they are closed, are above the plane of the basal ring. And you can see this easily on an echocardiogram, but a lot of people don't recognize it. The other thing to note is that the height of the free edge of the leaflet, it should be around about 9 or greater than 9 millimeters above the basal ring. And there should be at least 4 millimeters of coaptation apposition between the leaflets in order for the aortic valve to be fully competent. The other aspect about the aortic root, and again, I said that this is closely associated with the aortic valve, the two work together, is that the diameter of the sinotubular junction is the same as the vertical length between the basal ring and the sinotubular junction. Looking at that another way, you can measure the height of the commissure, and generally we would do this between the left and non-coronary leaflet of the aortic valve. And this is something that is utilised in operations to replace the ascending aorta, but leave the aortic valve behind. Now, some aortic valves are not trileaflet. Some of the aortic valves are what we call bicuspid aortic valve or bileaflet aortic valves, and there is an accepted classification, the Sievers classification, and it's type 0, where there are 2 leaflets without a ridge or raphe, type 1, where there is 1 raphe, and type 2, where there are 2 raphes. The orientation of these leaflets can either be in a sagittal orientation, which is the commonest, but they can also be in a coronal, that is a left to right orientation, and that may have some significance in increasing the risk of heart block after aortic valve procedures, which I'll go to in a little while. There are also, in fact, unicuspid aortic valves, very rare. Now, the incidence in the general population of a bicuspid aortic valve is said to be somewhere around about 2%. And the important thing from a clinical point of view is that more than 50% of these patients will need some sort of aortic valve procedure at some point in their life. Now, this picture is just to show you what is underneath the aortic valve. We looked at above the aortic valve. Now we're looking at just on the underneath side of the aortic valve. You can see here the left coronary leaflet. The aortic root's been opened up. This is the non-coronary leaflet. This is the anterior mitral leaflet. Now, many of the images that we've seen in previous presentations have shown this fibrous continuity between the aortic valve and the mitral valve. This is different on the right side of the heart, where there is a muscular bridge between the right atrioventricular valve, the tricuspid valve, and the pulmonary valve. That does not exist on the left. So there is fibrous continuity here. The other thing to note is that underneath this commissure between the non-coronary cusp of the aortic valve and the right coronary cusp, we have a membranous septum. And the membranous septum is basically formed by a number of processes embryologically. Initially, this used to be a foramen between the left and right ventricles, and this is before the tricuspid and mitral valves fully separate from each other, and also before the pulmonary artery or the pulmonary trunk and the ascending aorta separate from each other. So there is a foramen here, and that is closed by both the separation of the aorta and the pulmonary trunk, by the endocardial cushions separating the tricuspid valve from the mitral valve, and growth of the interventricular septum towards the top of the heart. And at the same time, the tricuspid annulus descends slightly towards the apex of the heart. So what happens is that the mitral annulus is around about here, but the tricuspid annulus is around about here. And so that creates an area here where we have an atrioventricular septum. The atrioventricular septum is a part of the left ventricular outflow tract in this area, which separates not the left ventricle from the right ventricle, but it separates the right atrium from the left ventricular outflow tract. The importance here is that the muscular component of this atrioventricular septum is where we find the atrioventricular node. And the Purkinje fibers of the bundle of His pass through to the left side at the membranous septum muscular interface at the bottom or the lower edge of this atrioventricular septum. Now, normally when we look at echocardiograms, we're trying to look for either pathology or confirm normal function of ventricular function or valves, but we often don't look for simple anatomy. And so if you look here, this is a transthoracic echo. You can see the mitral valve here, the tricuspid valve over here, but clearly you can see the atrioventricular septum here. It's not often appreciated because we're looking for something else. This slide here shows, again, this is another dissection that I did with Professor Fiona Stewart. It's looking from the left ventricle up towards the aortic valve. You can see the anterior mitral leaflet here. You can see the non-coronary and left coronary cusp, the knitting needle here across into the ascending aorta. And you can see here the fibrous continuity between the aortic valve and the mitral valve. If we look over on this slide here, you can see the tricuspid valve and the pulmonary valve separated by the infundibulum of the right ventricle. And the important thing to note here is that behind the back wall of the infundibulum of the right ventricle, the crista supraventricularis will be the right coronary cusp of the aortic valve, the right coronary sinus of Valsalva, and the right coronary artery origin. This is just a few more of the dissections that we did. We can look here at the aorta here, right ventricular infundibulum here. The knitting needle is actually underneath the infundibular branch of the right coronary artery, which is there. But this is just to show the relationship between the infundibulum and the aortic valve. This one here is seen from behind. Now, we saw some very compelling echoes and 3D images from CT from James Otten before looking at this area. What we're looking at in this area here is, in fact, the transverse pericardial sinus. I'll just explain it to you. The knitting needle is into the ascending aorta, into the left main coronary artery. Pulmonary trunk is in front, SVC here, roof of the left atrium here. You can see the bare area. This is where the pericardial reflection will, off the roof of the left atrium, will pass onto the parietal pericardium. So this is the left atrial appendage that we've just heard a lot about. So this is the transverse pericardial sinus, and it is an immediate posterior relationship to the aortic valve and the aortic root. Some people on an echo might think that the left atrium is behind the aortic root, but in fact the transverse sinus intervenes between the two. And you can see it again on this picture. Well, there are a couple of things we can see here. First of all, we can see the aortic valve opening and closing, and as it closes, you can see a nice area of coaptation, and you can see that it closes above the level of the basal ring, which we've spoken about. You can see the continuity between the anterior mitral leaflet and the aortic valve leaflets. You can see here the infundibulum of the right ventricle anterior to the aortic valve and the aortic root, and you can see the left atrial posterior to it. But what we've just discussed is that in this area here will be transverse pericardial sinus. And again, this is a similar picture, a short axis view. This is a transesophageal echo. This is left atrium posterior. Again, transverse pericardial sinus. You can just see a tiny little space there. Nowhere near as nice as Julie's echoes. I'm sorry, Julie. And right atrium on this side, infundibulum here, and this little dot here is the pulmonary valve just flicking into view. And again, you can appreciate here we have a trileaflet aortic valve with three sinuses: non-coronary, left coronary, right coronary. Now, this is a stenotic aortic valve. It's a surgical specimen. I have 2 more slides left. You can see this is aortic stenosis. The valve is thickened. The leaflets seem to be fused together. There is dystrophic calcification, and there really isn't much of an orifice. You wouldn't expect this valve to move very much at all. It's almost certainly going to be incompetent as well. So this is looking at it from the top. This is looking at it from the left ventricular outflow tract size aspect. The calcification frequently extends into the left ventricular outflow tract. It extends onto the left side of the infundibular septum commonly and into the aorticomitral curtain. It also tends to extend into the ascending aorta, into the sinuses, and often encroaches and sometimes surrounds the coronary ostia. And all of these aspects of the calcification and pathology that occurs in aortic stenosis does tend to make surgery challenging. Whether this is a trileaflet aortic valve or a bicuspid aortic valve with 2 commissures, it's difficult to say, but my guess is that it's probably a Sievers type 2 with a raphe here and a raphe here and a commissure here. But I think that's debatable. I think the valve has virtually been destroyed. And the last slide is not really anatomy. This is actually a degenerate tissue valve. This is a trifecta valve that has equally undergone dystrophic calcification and leaflet destruction And we are going to see a lot more of these in the future because tissue valves over the last 15 years have been put in younger and younger people who will outlive the valves, some of which will end up like this.